case of multiple cystic duct calculi which we encountered while doing a laparoscopic cholecystectomy. A female 34-year-old who presented with right upper quadrant abdominal pain, vomiting. She had no jaundice, no fever. Evaluation suggested a shrunken gallbladder which was thick walled with multiple calculi. CBD was normal, 4 millimeter in size. This was the LFT in which SGPT was 67, just above the normal limit, but rest of the findings were normal. Alphas was normal. So we proceeded with laparoscopic cholecystectomy. Now in the video we'll show you when we were trying to define the callots. This is what we encountered. There was one calculi which came out through the cystic duct. The cystic artery was clipped and we milked out the cystic duct calculi. The first calculi was milked out, and then after milking, we could see the mucus which was coming out. There was no free bile which came out. So we had a doubt that there might be again some calculi stuck up in the cystic duct. So we applied a clip towards the gallbladder and tried to remove the remaining calculi. So there is one more calculi which came out through the cystic duct. So till now the three calculi were removed. Now on the CBD we again saw CBD was not dilated. We continued milking of the cystic duct and we could feel some calculi are still there in the cystic duct. At the hole we could see this calculi here. So the milking continued and we tried to remove all the stones and see the gush of bile which should come out through the cystic duct. So while doing that, as the cystic duct, because of walls of Heister, the stone were not coming out. So while milking, there got a small rent in the cystic duct through which rest of the calculi came out. So we'll see here. One of the option of doing this was, see there is a calculi which you can see. That was the point through which the calculi started coming out. Now, one of the fear which we had at this point was might be there some stone which have gone into the CBD. So we showed this to the relative on table that there might be a chance that some stone might have slipped into the CBD. One of the ways of looking that was an intraopcolangiogram, but we thought of proceeding ahead with the cholecystectomy only, and we counseled the relatives that the patient might need a ERCP if there is any CBD stone the cystic duct stone which might have slipped down. So now we are seeing bile which is coming out freely. So we are sure that there is no cystic duct calculi anymore. So to take care of these, you can do an intraopcolangiogram to see whether there is any CBD stone or not, or you can actually look it into the ICG. We didn't have an ICG system where we can actually see if there are any CBD stones or not. So as expected, as multiple calculi were removed, this patient on post-op day 1 had a severe abdominal pain. The pain was exactly as it was before the surgery. There was no tachycardia and jaundice. And the LFT on post-operative day 1 showed a derangement. So this is the derangement which we saw. An ultrasound was done which showed a mildly dilated CBD. So the patient was taken up for an EUS examination in which we could see the stone in the distal CBD. This is the posterior acoustic shadow. At the same time, we did an ERCP and removed the stone. So preoperative LFT in this patient we had seen. It looked normal. Preoperative ultrasound was normal. But intraoperative, we had cystic duct calculi which we had to remove. So we counseled the patient immediately during the surgery itself, relative itself, called the relative inside the OT and showed him the cystic duct calculi which were coming out. That actually helped us in counseling the patient post-operatively to get an ERCP immediately. Any post-operative abnormal course, that is a pain which is severe after the surgery, has to be evaluated and has to be treated the way we did in this